bringing together voices in child and youth healthcare. This is CAFC Presents.
CAFC would like to thank the following member organizations for their generous support of our knowledge translation activities: the IWK Health Centre, the Children's Health Foundation of London, the McMaster Children's Hospital Foundation, the Children's Hospital of Eastern Ontario Research Institute, the Children's Hospital Foundation of Manitoba, the Montreal Children's Hospital Foundation, the Holland Bloorview Children's Rehabilitation Hospital Foundation, and the Children's Hospital Foundation of Saskatchewan. We would also like to thank the following Keystone and program partners for their ongoing contributions that support all of CAFC's programs and activities. If you have any questions or comments for our panelists, please type them into the question box at any time during the presentation. You can also share your thoughts and questions on Twitter by tagging @CAFCTweets and using the hashtag CAFCPresents. All of our webinars are recorded and can be found on the CAFC Knowledge Exchange Network. Use the Ken to share these recordings with your colleagues or register an account and post comments, links, or other resources that you think will be of interest. And be sure to sign up for the CAFC Presents weekly email newsletter to stay up to date with upcoming webinars and our recorded webinar archive.
Hello, everyone, and welcome to today's episode of CAFC Presents. I'm Doug Maynard, Associate Director at CAFC, the Canadian Association of Pediatric Health Centres. And today's webinar is titled Mental Health Problems in Children with Neuromotor Disabilities. And it's my pleasure to welcome Dr. Benjamin Klein to the CAFC Presents stage today. Dr. Klein reached out to us quite some time ago, a few months ago, after connecting with some of our colleagues from the CAN Child Centre for Childhood Disability Research, who felt who suggested to him that a topic on mental health and children with disabilities might be, with neuromotor disabilities, might be of interest to our audience. And there's absolutely no question he's right. Those are two very hot topics that our community is often interested, both children with disabilities and issues that they face, and mental health in general. So this is going to be an interesting conversation over the next hour that we're going to be having. Dr. Klein is a developmental pediatrician at the Lansdowne Children's Centre in Brantford, Ontario. He's an assistant clinical professor in the Department of Pediatrics at McMaster University, and he's a member of the Developmental Disabilities and Mental Health Committee of the Canadian Pediatric Society. And Dr. Klein was supposed to be joined by Linda Field Newhouse, who's the Family Service Coordinator at Lansdowne Children's Centre in Brantford, but unfortunately something's come up and she's not able to join us, so Dr. Klein's going to be carrying the presentation on his own. So without any further ado, I'm going to hand the virtual podium over to Dr. Klein. Over to you.
Okay. I'd like to just thank you for this opportunity to present this work. Unfortunately, Linda, my colleague, has had a family emergency. She won't be able to present, but we have given this presentation before, so hopefully I can represent her contribution, which is more from the social work service coordination side. So I'll be presenting today on mental health in children with motor disabilities, and what I'm referring to with neuromotor disabilities is conditions like cerebral palsy, spina bifida, muscular dystrophy, although I won't really be talking about conditions specifically, but all conditions that can affect motor function as the predominant feature and can have a very variable presentation in terms of other disabilities such as cognitive and communication. And there's just a little snapshot of our position statement, which is a great deal of focus on kind of what does the general consultant pediatrician do, but also directed towards any physicians that are contributing to the care of children. And obviously, physicians don't practice in a vacuum, particularly with respect to children and their families with disabilities. So we're just a piece of the puzzle there, and working together with the bigger team. And in this presentation, there'll also be an emphasis on the kind of deeper structure of the child-parent interactions that might fall under the domain of social work or other disciplines who do that work, and service coordination in the broader community and the different agencies, if you will, education, medicine, so on. So I'll start with some cases just to illustrate the types of kids we're talking about and some of the challenges. and we'll revisit these cases later in the presentation, providing some more detail. So the first case I'd like to present is a 12-year-old boy who presented initially, who was ambulatory but had motor delay and lower limb pain, and who eventually had a diagnosis of Becker muscular dystrophy. And at the time was also having difficulties at home with frequent escalating arguing and irritability, non-compliance with parental requests, excessive use of electronics, and sleep disturbances at night. This is in the context of a single-parent family who, for whom the mother had lost custody of her other children and were living in a different province. And this is now the only child that she has that's living with her, and the implications of a genetic diagnosis that may affect other family members, and the difficulties that she was going through. Sorry, a little behind there. So another illustrative case, a 9-year-old boy with gross motor function classification system level 3, spastic diplegic cerebral palsy, who actually met in the emergency room, and he was presenting with intrusive thoughts, tantrums, and irritability, and specifically intrusive thoughts around puberty and sexuality that were highly disturbing to him. This is also an individual who had some difficulties with accepting help. For example, at school, not wanting to be different. He was not going to the bathroom all day in school, needing help but having a hard time accepting it. In a family context where parents were separated, he's living with his mother predominantly, who's having difficulties with chronic pain, substance use, and depression. So the third case that I'll review is a 2-year-old with gross motor function classification system level 4 cerebral palsy, who has a history of prematurity and was presenting with some increased crying and resisting care, as reported by the parent. And this is a child who lives in a family with a mother and a father, and several older siblings, including a normally developing twin. And in the presentation, and this was at the result of quite a bit of work with our therapists and social workers, emerging that mother struggled with feelings of feeling selfish, as what she felt that the community's perception of her having too many children, feelings of that God was punishing her for being selfish for having too many children, and struggling with having the child be visible in the community. So as an example, this is a child who would have been able to go out for Halloween in a stroller, but was kept inside. Okay, so those are just cases that I just like to keep in mind in terms of the types of kids and families that we're seeing who are presenting with what we're calling mental health symptoms. So just some definitions to clarify kind of what we're talking about. So as mentioned, neuromotor disorders, I'm talking about conditions that predominantly affect movement or posture, or defined as such, but can have a wide range of other features. So very high level of variability in cognitive communication, social skills, and recognizing that each child really is a unique package of functional abilities and individual factors such as preferences and temperament. What is child mental health? And that's certainly not easy to define. I think as a profession, we continue to grapple with what that means. Certainly mental health symptoms like sadness or behavior are normal, although we don't like to use that word. They're not necessarily a disorder. I'd like to think of mental health as social, emotional, behavioral development, although I'm a developmentalist, so I guess that's a bias. Certainly, mental health symptoms can be part of a psychiatric disorder like bipolar disorder or major depression or schizophrenia. That'd probably be the exception rather than the rule, that a child with a neuromotor disability, especially prepubertal, is going to present with a nice packageable psychiatric disorder. And what we're seeing mostly is that mental health symptoms are in the context of a lot of risk factors or possible contributing factors, including symptoms such as agitation, noncompliance, or anxiety that's in the context of interactions between mother or father or other parent or caregiver and child. Okay, we're back. So mental health symptoms in neuromotor disorders. So anxiety, so advanced. Anxiety you may think of as an excessive fear where a danger doesn't really exist. However, if you're a child where there is a real danger, if you're in a wheelchair, unable to move, dependent on others for your basic care, then what does that fear of death or vulnerability mean? It's getting hard to assess. Advanced mood symptoms, adjusting to difficulties that are not as a part of typical development, such as being unable to do things that most other children can do, guilt, and feeling worthlessness. We may think of school-age kids as often you feel you are what you can do as a theme kind of in school age. So how to assess mood in a child that's struggling with those difficulties. Externalizing type of behavior, such as hyperactivity. I mean, how do we assess attention deficit hyperactivity disorder in a child in a wheelchair? We're not really there yet. That's difficult. How do we assess inattention as a possible primary mental health symptom in a child with many other possible causes of inattention, such as communication difficulties, pain, or not being in the right position and having difficulties communicating that. For children as they become teenagers, considering that having mild acne might be traumatizing for a typically developing teenager, what does needing to go to the bathroom with a caregiver and be catheterized for urination, in terms of stress for an adolescent? How do we assess, the emotions that someone's going to experience within that situation? So next slide, MH and neuromotor disorders. So the rule that we see is that understanding mental health symptoms is more complex, more multifactorial. We know that children with neuromotor disorders have more mental health problems than typically developing children. We know that mental health symptoms often don't fall into neat diagnoses. What is normal is not an easy question, maybe not relevant, and often there's more than one cause to a child's possible, what we're calling mental health symptoms. Assessments can take a long time, require multiple collateral historians, including therapists or teachers. And we also scientifically know that families, parents have poor health, mental health, and a parent that's struggling with stress and mental health in the context of caring for a child with complex needs can affect the quality of the home environment and set up a vicious cycle that may manifest with mental health type of symptoms. Parents experiencing stress, anxiety, and fear regarding their child's well-being, financial strain, possible guilt. And for parents may have difficulties with literacy or information technology, parents who may be newcomers to a country. All this can affect parenting capacity, which can in turn affect the emotional state, mental health symptoms of a child. Next slide. What is behavior? Behavior really is a term that should be neutral. Behavior is just kind of what people do. It's really taken on the meaning of not just behavior as bad and as a symptom, but behavior that is something that a child is doing volitionally. Like if that's a word, something the child is being bad on purpose. Often the word behavior as a symptom takes on that meaning. But really, behavior as a symptom is very subjective. It's hard. It depends on the point of view of the caregiver, the parent, the teacher, who's ever interpreting it. Behavior is necessarily transactional. It's interactional. It takes someone else to perceive the behavior as something problematic. And behavior is in a continuum with just normal behavior, normal activity. And that's subject to interpretation as well, and can be contributed to by many factors. For example, a child may be acting out or calling out or crying because of pain or because of a feeling of being left out. So next slide. Stress, i.e. a mechanism of behavior. I often find that conceptualizing behavior in terms of emotional stress homeostasis, or around here, I like to talk about a stress tank. And as the child's tank fills up with stress, it may fill up, and then the brain will flip to a fight or flight state that the individual child may not have under control. So stressors may include a feeling of inadequacy, not being able to participate, pain, and the amount of stress someone has a normal range in which the child is able to maintain functioning. Too high or too low will cause symptoms. So go to the next slide here. How do we diagnose mental health problems in children with neuromotor disorders? I might ask the question, how do we diagnose mental health problems in any child? So let's look at some of the frameworks that we can use to make diagnoses. So next slide, the medical model that's the Diagnostic and Statistical Manual, the DSM. It's essentially a categorical system, although they have been bringing in more qualifiers to give it a bit of a more dimensional aspect, but essentially it is a categorical system, and the problems are defined by symptoms in a person, in a patient, rather than an interaction with the environment. And the medical model usually attributes one cause in a one direction way. Let's go to the next slide. The D's diagnoses are categorical diagnoses that package up mental health symptoms into discrete diagnoses. And whereas it seems that there is a primary attention deficit hyperactivity disorder, the symptoms of hyperactivity and attention are so subjective and not so specific, even in a child without a neuromotor disorder, that diagnosis can be difficult. The diagnosis of oppositional defiant disorder is not one that I personally use. I find that the meaning that people tend to get from it in reality is that the children are doing things on purpose, and that's not something that's accurate. And I find that it can be stigmatizing or harmful, so I tend not to use that myself. Advanced slide. Diagnostic systems have limitations. Clearly, for children with neuromotor disorders, when considering their mental health and mental health symptoms, the medical model just isn't enough. We need something else. So, next slide. It's really the international classification of functioning framework that helps us understand the many contributing and interacting factors that lead to a final common pathway of what we might call mental health symptoms: sadness, crying, quote-unquote behavior. So by way of example, a child might have a mobility difficulty that in a given environment with a certain set of supports may not be able to participate in activity, which may lead to decreased social and communication interactions, which may lead to suboptimal development of those functions in the child's brain and increasing difficulty interacting with people in various environments, which may ultimately lead to that child feeling sad and having less inclination to participate, less motivation. Go to the advanced slide. So I'm going to review with really the meat of our position statement, which is a clinical approach using the International Classification of Functioning, which I like to think of as a differential diagnosis of interacting contributing factors, which is a bit of a long-winded phrase, but I think that we need to recognize that we're not going to find one cause often, but we're going to have to look for multiple possible causes, including physical pain, neurologic causes, and interactional difficulties between the child and the environment, which may be at home with parents or in a school setting or otherwise in a community, that we're going to try to identify that are possible contributors to what's emerging as a mental health symptom and maybe causing a vicious cycle. So the end game really is to optimize a child's participation, which you can see as both a treatment and as an outcome. Next slide. Medical assessment process. These are children and families that require a fair amount of time in order to get all the data required to understand the child's situation. We'll need multiple visits, often multiple informants. Parents may or may not have copies of other people's assessments. The providers, such as therapists, doctors, social workers, educators, may be geographically far-flung, and there may be more or less ability to communicate electronically. A function review of what can a child do in all of the domains of functional abilities. We need to figure out the motor or the mobility, the fine motor, the communication capacity, overall cognitive abilities, social skills, executive functioning, and so on. Only when we get a good snapshot of what the child can do are we able to assess what is the environment expecting them to do, how is the environment supporting them, and how a possible mismatch of a child's abilities in any of those areas might be contributing to the stress of not being able to participate, thus leading to mental health symptoms. A medical review, of course, required to identify any possible sources of pain or medical discomfort, and an individual review of what's fun, what are the child's preferences, and what's their individual temperament. Of course, fun being one of those things that's a physiologic stress reducer. Next slide, body structures pain. So from a physician's point of view, the children require a detailed musculoskeletal inspection, looking at joints and skin and so on. Gastrointestinal problems, constipation and reflux being common sources of pain and discomfort that may be difficult to detect, as well as swallowing difficulties. Really, anything that any child could get, a child with a neuromotor disability could get. And often these kind of, if I could say, normal or typical or mental or medical conditions like asthma or celiac disease or anything else might be a significant source of discomfort leading to mental health symptoms that would be difficult to detect. Our advanced slide, please. Body structures, neurologic. Children can be having seizures, which may be manifesting as inattention or staring spells or tuning out, may be mistaken for attention deficit hyperactivity disorder symptoms. Seizure medications can have their own side effects, and children may have changes to their neurologic status and may be presenting with behavioral symptoms that might be part of the natural history of a neurodegenerative or metabolic condition. So, advanced slide. Functions. What can you do? Well, children or any individual has various domains of functions in which everyone has a level of ability. This can be obviously challenging to assess and requiring often a multidisciplinary team to figure out at what level can a child do things, and that can tell us how that's stacking up with an environment which may be causing barriers to participation. So by means of a small example, we all see children at times who may have a very severe physical disability, but cognitively they can have a significant relative strength, even compared to typical children. So a client that we've served in our center was found in grade 6, someone with a gross motor function classification system level 5 cerebral palsy, who required constant care, being in a motorized wheelchair, who at school was in a class watching preschool level cartoons such as Dora with other children who may have had levels of cognitive and social ability. So you can imagine the stress involved in being a cognitively typical 10, 11-year-old being forced to watch Dora. This is an individual who eventually went on to go to university. Advanced slide. Environment. What are you asked to do? Part of the comprehensive assessment is to understand what are the expectations in the environment across all domains, which helps us understand where discrepancies may lie in a child's abilities, environmental demands, and support required that may be leading to stress. Children require enough physical support and accessibility in order to participate. And in the home environment, children may be asked or they may be put into a role as part of the family, such as the baby of the family, a disabled person, and the interactions in the family may be habitual or learned or reinforced in terms of that role that a child takes in the family. As children are getting older, bullying and in school age and adolescence, a peer environment can be a culture of cruelty at times. We have seen teenagers with disabilities who require urinary catheterization to be sprayed with air fresheners by peers as part of bullying, and the attitude and environment among peers and teachers and in the community can have a large impact on the self-perception of of a child or adolescent. Just by way of example, of a client that we served who has gross motor function classification system 3 cerebral palsy, so someone who may require a cane or a walker at times, who was able to walk and in high school had a fair amount of environmental support, including strategic placing of books and lockers and use of elevators and so on to get to the different classes. But when this individual went to university, the same supports weren't in place. The individual wasn't able to go back to his room to get books, so had to load all of his books in a backpack. That caused more weight, and the far-flung distances between classes caused a lot of physical strain, joint pain, difficulty sleeping, increased anxiety of failing at university, and a vicious cycle ensued. Next slide. Individual factors. All children have a unique temperament, which you could describe as a resilience level or tendency to react to environment. As I like to say, congenital self-regulation tendencies. So how flexible, how much does your stress tank fill in the face of a certain stressor? For example, if the environmental demand is outstripping your functional ability, how much stress does your system accumulate because of that? Kids have their own unique predominant mood, which other caregivers or other people in the environment, peers, are going to react to. Depending on the interactions of people around them, children feel more or less involved and supported and able to participate in peer interactions, which can have a complex effect. Children may have a different reaction to anticipating a decline. For example, having to go into a wheelchair for a child with Becker muscular dystrophy, how they deal with information on the internet about their condition, how they deal with stigmatization and the stress of people looking at them in society, and how that affects the individual person's participation. Next slide. Participation requires adequate supports to be in place for an individual person, and it's highly dependent on the individual environment, whether that's school or home. And positive participation we're seeing as both a treatment and an outcome in terms of mental health and quality of life in general. Next slide, formulation and plan. The big picture is, for the physician and for the team in general, I suppose, is to get a best understanding of a child's profile of function, their individual factors, and all the possible factors that may be contributing to whatever symptom that the child is presenting with: sadness, acting out, anxiety, agitation, and so on. To communicate that understanding to parents and to discuss options for supporting the child, for changing the plan, recommendations for intervention, whether that be addressing medical factors like constipation or possible reflux, reassessment by an orthopedic surgeon for joint issues, seeing participation in recreation or fun as an intervention in itself for mental health symptoms that may arise because of shortfalls in participation that the child may be able to engage in, and to address parent-child interactional difficulties, so limit setting, positive physical nurturing interaction, addressing bullying and stigmatization in any environment such as school, and facilitating it as best peer interactions as possible. Children may require advocacy letters for school to help put in place an optimized situation in terms of being able to be most productive with schoolwork. Obviously, there's many possible, for each individual child, there's many possible routes in terms of supporting a child and moving forward. There's an issue of having to prioritize goals and steps and to communicate amongst all the members of the team, which may be in a children's treatment center, in a school, in a recreational facility, and that's not an easy task. And every system is going to may deal with that differently. Next slide. Physician roles. In terms of the physician, which would typically be a general consulting pediatrician in this neck of the woods, obviously a comprehensive medical assessment requiring some skill in multiple areas, including the functional assessment, the medical assessment, orthopedic, and being able to recognize and act on possible problematic areas. The physician often is the medical coordinator of care, who may be at the center of the who's doing what in terms of specialty physicians, and also coordinating with non-physician members of the team. So next slide. Often this team may be virtual. So a physician may be in a developmental center or tertiary academic medical center, or maybe in an office in a rural setting, far away from other supports. Of course, the family is the center of the team and really the key to it all. If they need to be empowered and to have the ball to understand, all the information, because ultimately they're a big part of any intervention or support moving forward. So I'd like to go now to our polling questions, if that's all right. I just have 4 questions that would be really interesting to know how people feel about their own systems that are supporting children with disabilities, especially with respect to the mental health symptoms. So, Doug, if you could.
Yeah, so we're just going to launch our first poll question. So the first question that we're going to ask is, in your region, how do children with multiple needs and their families access services across agencies? For example, rehab, mental health services, school, etc. And the options, the choice options, are service providers within an agency make direct referrals, or families need to go through each agency's intake process, or families need to go through a single point of access agency, or some combination of all of the above. So this is your chance to just go up onto the screen, make your selection, and once we give everyone a chance to make their selection, we'll show the audience what the responses are. So we'll just give everyone just another second to put in a response. So we'll close that off, and it looks like most people have some combination of all of the above. But other than that, the next most common answer is 17% said that families need to go through each agency's intake process.
Okay, maybe we could go to the next. We'll just go through all these polls, if that's all right.
Sure, yeah. So the next question is, in your region, how family-centered do you find the process of accessing services across agencies? Highly family-centered, somewhat family-centered, not very family-centered, or a complete disaster? Hopefully we won't see too much in that category. And I'm happy to say that no one said a complete disaster. There is some hope out there, I guess. 54% said somewhat family-centered is the most common answer, followed by not very family-centered. Only 9% saying highly family-centered. All right, and the next question is, in your region, which best describes how coordination of care is organized? The answer choices are: an individual care provider is identified for each family. A service provider informally carries out this role. Most don't have a consistent service provider in this role. Or access to coordination of care is quite variable or even non-existent.
And if I can just add, this is mostly referring to not the medical coordination of care, but more the coordination of services.
All right, we'll close that off. And it looks like the most common response, at 34%, have said most don't have a consistent service provider in this role, followed by 30% saying access to coordination of care is quite variable or even non-existent. An individual care provider identified for each family, or a service provider informally carrying out this role, about the same at 17 and 19% respectively. All right, and the last question. In your region, difficulties in accessing coordination of care for families of children with a neuromotor disability does not seem to be a significant problem, seems to be a problem for a minority of families, seems to be a significant systematic barrier for many families, or is a complete disaster. And only 2% have said it's a disaster. The most common, at 51% of people say it's difficulties in accessing coordination of care for families of children with a motor disability seems to be a significant systematic barrier for many families. Followed not too far behind at 37% seems to be a problem for a minority of families. Only 10% saying it does not seem to be a significant problem at all.
Great, thanks very much. Okay, that's very interesting. So thanks everyone for contributing. I'm just going to go through the next slide here and just kind of revisit those cases that I presented at the beginning, and just to add really some points that just to illustrate the many areas that we may have identified as possible contributing factors to suboptimal child well-being. So just kind of move ahead a couple of points here. So helping the parent implement limit setting and rules for electronics, for sleeping, and involving a child and youth worker to provide more feet on the ground support for that parent. This is someone who, during a school meeting and some further questioning, we identified that this is a boy who was going with his friends to a variety store at lunch, which was several blocks away, and coming back quite fatigued to a classroom where it was a science classroom, and he was sitting in a stool, not in a seat with a back. So coming in like a fatiguing activity, coming back to suboptimal seating, and we re-involved the physiotherapist to optimize orthotics and so on, and treated his constipation. Everyone's constipated here. So that's good. We'll go to the next slide. And so the 9-year-old who was presenting with intrusive thoughts was diagnosed with obsessive compulsive disorder. So, some children are going to have kind of straight up axis 1 disorders, and that are part of the picture and are going to require sort of that standard medical treatment. So was treated with an SSRI medication and sort of did well with that. This is someone with an individual temperament who has difficulty with adaptability. So helping parents understand that. So psychoeducation and using that information to try to help parents with collaborative problem solving with the child, in balance with setting limits and allowing him to kind of direct the show and kind of direct to his own interests, which this being a very intelligent boy, he's building racers and all kinds of things like that. And at his happiest when he's involved in those things where he could really exercise his strengths, which is his cognitive abilities and visual spatial problem solving. So let me go to the next slide. So the 2-year-old we treated for constipation, of course. Connected this family with service coordination in order to help the parent work through some difficulties with participation and in the environment. So getting the child doing fun things and helping the parent interpret crying and resisting in terms of communication, and using that, trying to read the cues and have build up a repertoire of responses. This is a child who we found to be sensory sensitive to noise, so decreasing the noise and visual stimulation in the environment to help facilitate the child being more emotionally settled in a sort of stress regulation point of view, and helping the family connect with a daycare early childhood education therapist to help integrate into that environment, as well as referring to ongoing orthopedic surgery monitoring. Okay, go to the next slide here. So I have a disclaimer at this point. What I say doesn't necessarily reflect the Canadian Pediatric Society. These are kind of my own thoughts and maybe an amalgamation of discussions and so on. And I am not a policy expert, but I'm a pretty feet on the ground kind of clinician type of person. So there it is. I think that timely access to medical care and having all the pieces is just so critical to optimizing kids' well-being, ongoing health, quality of life, and so on. I think personally that this is the biggest challenge that's facing us in terms of supporting these kids. Let's go to the next slide here. So I think necessarily our roles need to be a bit fluid. Sometimes, we're a doctor or a therapist playing the role of a coordinator. Sometimes we're just kind of doing our typical job. Sometimes we need to step out of our comfort zone and just say, I think the main issue maybe is not in my usual domain, but it seems that it might be this. I think this is where we need to go with that. So sort of the blurring of the lines of the usual discipline, I think it's just something that we need to get more comfortable with, obviously within reasonable limits. So we're making sure we're not just doing our jobs, but we're making sure we're trying to get to the whatever is affecting the child and family most in terms of what's leading to mental health symptoms, quality of life. It's all the same, or it's all related rather. As mentioned, I would kind of, it's all coordination, but there's certainly different pieces to the coordination. There's the medical coordination, which would be usually the physician or perhaps a nurse practitioner who's pulling together all the information, making sure all the medical pieces are there. So, for example, making sure the orthopedic surgery is in the picture. If specialized feeding, swallowing, or gastrointestinal people are needed, treating what falls under the domain of the more generalist type of physician or nurse practitioner, like constipation or reflux, considering any medical condition that any child could get, and some way to have effective communication on a timely basis between all the silos that are important in a child's life, including medicine and the therapy development center, the school. We need to all get on the same page. And in Ontario, anyway, I mean, the government's done a lot of work coming to those conclusions that families need more seamlessness, less having to tell their story over and over again, and so on. That's certainly something that in the trenches, I'm sure everyone will agree that's a significant barrier for many kids. And I think our poll has brought that out, which I'm glad. Well, I'm not glad that it's a problem, but it was I think it was shown there. And I mean, we're often throwing around the term family-centeredness, but like, kind of, what does it mean? It's kind of like evidence-based. Like, what are we actually talking about? So, are we really allowing like the family needs and preferences to have enough influence on, what therapy happens when, like, your number came up for speech language therapy, but like, is that really what you want or what you can deal with right now? So sort of, I think there's levels of family centeredness, and I think we need to have a better mutual understanding across the symptom what that actually means and how we're going to get that done. And I think family centeredness is a lot coordination. So if there's effective coordination, then that's going to facilitate somebody knowing the family well, having that trust, and being able to have that family and child be able to express their preferences and concerns that will lead to more effective care and supports and intervention happening that's actually useful and supportive for the family, which can be harmful and stressful if it's something that they just are not able to handle. Just adds complexity, adds more stuff to juggle. So next slide, please. Getting help, getting support is definitely a challenge in many areas. Pediatricians just don't get enough training in mental health, in development. We're really, as residents, grinding the gears of the ivory tower intensive care units. I mean, that training is important, but what general pediatricians are asked to do in society is in large part supporting children with developmental, behavioral, school problems, disability, mental health difficulties, and a combination of all those things. It's just, the training's just not adequate in my opinion, and I think that needs to change. Access is just hard for subspecialists that do this work, and in terms of moving away from physician stuff, we need to find some way of systematically making sure families who need coordination get it, whether that's their physiotherapist who has that capacity because they know that person well, or whoever, or a specialized coordinator of service coordinator. I think many people have probably run into the situation where mental health agencies don't do physical disabilities and developmental agencies don't do mental health. I think, we're allowed to be specialized, I think, but I mean, these kids are they're a package, and I think we need to break down the barriers. And of course, there's always wait lists, funding issues, age cutoffs, which makes for a very complicated system. And the more of this kind of red tape we have and restrictions, the more we need coordinators and system navigators and so on. So I think we touched on this. So we move to the next one. So I only know Ontario obviously very well, but people have to be, in order for this work to happen, like if you pay them, it will happen type of thing. The system needs to fund the work appropriately if we expect it to happen. We have to prioritize the kids' needs in the system and recognize that children with neuromotor disabilities require a pretty significant amount of care, and we need to direct the resources appropriately because those kids need it and the families need it and they deserve it. And we need, in my opinion, more training in general pediatric residency in these areas, as mentioned. Next slide, please. In terms of coordination across the system, every area is going to be unique. I certainly have concerns about a system that doesn't allow for enough ongoing coordination of care with a human that knows the family and has established trust. That really can't be done by an agency. It has to be a person. And I mean, that person may change depending on circumstances, but I think in order to serve these kids and families properly, it needs to be a model of ongoing care and a system where you allow clinicians to connect with each other directly across agencies without needing to go through bureaucracy unnecessarily. So above all, I think the families needed a clear message of, as professionals, what's our understanding of their child and family situation, and in terms of why are we where we are? Why is this child having symptoms or difficulties? And it's going to be a consistent person who knows that family well, who in combination with a medical person who knows that family well to deliver that. In our region anyway, I think there's an opportunity to develop better communication between silos. I think we're challenged by privacy and information technology, perception of insecurity. The question being, yes, there's risk in communicating, but what's the upside of having everyone in a child's circle of care being on the same page? So there's risks to shortfalls in communication, just like there's risks in communicating. I'm an advocate for clinicians, service providers being able to talk to each other even if they don't work in the same building or under the same agency, because I think the child's agenda is optimized when we allow the clinicians, the service providers, to talk to each other directly without red tape, without dubious intake processes. Next slide, please. So I don't think we need a randomized trial to show that improved coordination is good, although I would certainly be interested in seeing a randomized trial. It hasn't been done, but I think that coordination obviously is going to lead to better outcomes and have a knock-on effect of less utilization of resources. Obviously, a child that's having fewer difficulties and has more positive participation is going to be less stressful for family members, so kind of creating a virtuous cycle. Okay, and that's the end. So thanks for listening, and happy to have a discussion or questions, comments.
All right. Thank you very much, Dr. Klein. Great presentation. We are a little bit over time. We do have a couple of questions that have piled up, so we will take a few questions. We'll try and keep everybody a little bit past the time that we had scheduled for this and get some answers to these questions. But so if you do have questions, please do type them into your question box as quickly as you can. The first question that came in was from Gail, and she's saying, this was probably about 10 minutes ago it came in, the question came in. She's asking, how are the goals of the child or youth incorporated into the treatment plan? And how is that plan communicated to the children and youth to help with their positive involvement?
That's a good question. And I think it's part of the assessment really is to try to determine what are the functional abilities of this child in front of me, verbally, cognitively, socially. And so how can I ask you things? Can I ask you, do you have pain? What do you like? What's fun? What's bothering you? So I think it starts from the beginning. As a kind of a garden variety clinician, I just try to engage the child ask them questions. You never know who you're talking to. Kids can be quite locked in. Like they may have a severe motor disability, but be cognitively have a great strength, and just it may not be obvious. So ask the child, ask the parents what the child says or how the child communicates, to just try to get as much as you can and involve them kind of from the first moment you meet them, and try to, based on the assessment of where you feel the child is developmentally at, you could provide an explanation of, like, I think that you're having trouble because your hip really hurts. Pause and see what you get, and this is what I think we should do in as developmentally appropriate a way I can say that to that child. Does that answer the question?
Yeah, I'm sure it does, and I'm sure Gail will put in a follow-up comment if she wants any more further clarification. We did have the next question that came in is from Veronica. She's saying, excellent presentation and lots of great discussion points. She feels you have identified some of the major barriers to success for these children. For example, ineffective care coordination models, perceived barriers in electronic communication, not allowing families to choose who coordinates care for their child. For example, a therapist who knows them well versus a care coordinator who redirects them and gets them caught up in bureaucracy. So, she really feels you've identified lots of those barriers. And this is a lot of what the conversations in CAFC's community of practice on children with complex medical needs, this whole concept of care coordination and some of the navigators and that sort of thing that happens there. So, she's really appreciates you raising a number of these issues. Benjamin's asking, have you heard of any attachment-based early interventions being successful in supporting parents and children with adjustment to diagnosis and or mental health concern prevention?
I'm not aware of any specific attachment-based programs, although I am, in this context of neuromotor, I am as familiar with attachment-based programs or infant mental health, for example, the Circle of Security. So the answer is no, but I do think that children, there's certain common concepts in children's emotional development and the need for parent-child interactions that you could extrapolate the Circle of Security for kids families that may be struggling with trauma or stress. That you could extrapolate to children with motor disabilities, if there isn't a program that exists, which I don't know of myself.
All right. Well, thank you very much for that. I think we are pretty much at the end of the questions. As I said, we are a little bit over time. I think people are starting to drift off as they have to actually get back to their jobs that actually pay them, as opposed to sitting around listening to us today. But I'm just going to hand it back to you for one more. Any final closing comments you'd like to leave the audience with? Any key messages that you'd like to sort of end this off with?
I think it's been, if the questions and comments are an indication, I think it's, the coordination of both medical and service coordination as what I see to be the biggest opportunity to improve the situation for these kids.
All right, and I think a great comment did just come in, and it is just a comment, not a question. Kathy's saying, excellent presentation. Your presentation has empowered her to continue advocating for care coordination. So in her area, so that's great accolades right there, that you've empowered her to continue on with these conversations in her own area at least. So thank you very much for that great presentation, and thanks again to the audience for joining us today. We do our webinars every Wednesday at 11 a.m. Eastern Time, and it's always great when you can watch live, as these kinds of questions and conversations really enrich the discussion. But when you can't watch live, as I mentioned, we do record these sessions and make them available after the fact on our Knowledge Exchange network. Next week, coming up, we'll be hearing on December 7th, we'll be hearing from Carol Keller, who's bringing the F Words to Life and a therapeutic recreation and wellness program. Their program the Leisure and Fun Environments program at the Rehab Center for Children provides in Winnipeg provides therapeutic recreation programs using a family-centered developmental approach. So I think lots of the folks who are participating today will be very much interested in that one. And that's really she described it as an opportunity to implement the F words, which we've heard lots about on our webinar program from Dr. Peter Rosenbaum and Dr. Jan Willem Gorder, who wrote that F words paper so long ago, and it's really generated such conversation around those concepts. And then following that, on December 14th, we'll be hearing from CJ Curran and Dolly Menadak from the Holland Bloorview Kids Rehabilitation Hospital, where they'll be talking about the importance of peer-to-peer connection for the children and youth that their hospital serves. And that's really a follow-up from a presentation that they did a while ago on sort of peer support. And this is now focusing on that program, but from the perspective of youth mentorship. So again, it's a couple of great presentations, I think very much in the area of interest of our folks who attended today. And we're also in the process of compiling our best of that we do every year at about this time as we head into the Christmas break. So we'll be sharing over the next couple of weeks on our CAFC Presents newsletter what some of our most popular topics were of the year. So everyone, we always have a lot of fun with that. So keep your eyes open for that in the coming weeks. So as always, great stuff coming up today. Thanks again for joining us for such a great presentation today, and we hope to see everyone back here next week. Bye, everyone.